Welcome to the Immune Deficiency Foundation's Young Adult video series. This video was created to provide an understanding of intravenous immunoglobulin and subcutaneous immunoglobulin. My name is Adam Freestone, and I'm the Senior Creative Director at the Immune Deficiency Foundation. Before we begin, I'd like to introduce Margaret Mary Conger, Senior Patient Engagement Associate from CSL Behring, to say a few words.
Hi everyone, it's my pleasure to speak to you on behalf of CSL Behring today. CSL Behring is proud to sponsor the Young Adult video and webinar series for the second year. We at CSL recognize the importance of patient education. I hope that you watch each of the videos in this series because the information is so valuable. The better informed you are, the more prepared you will be to make important decisions about your care.
Thank you so much, Margaret Mary, and thank you to CSL Behring for sponsoring this great program. Our presenter for Understanding IVIG and SClg is Dr. Mark Ballow. Dr. Ballow serves as an allergist immunologist within the University of South Florida Morsani College of Medicine Division of Allergy and Immunology at Johns Hopkins All Children's Hospital and is a member of the IDF Medical Advisory Committee.
What is immunoglobulin replacement therapy? Well, immunoglobulins are derived from the plasma, and the plasma undergoes purification to separate the immunoglobulin G portion of the plasma. Usually a batch or a lot of immunoglobulin for replacement therapy is made up of a donor pool of around 10,000 normal individuals. These individuals come to a plasmapheresis center where they donate their plasma for the production and purification of the immunoglobulin. So immunoglobulin or gamma globulin, some people use that term interchangeably, is made up of highly purified IgG, anywhere from 95% to 98%. There are other plasma proteins in the gamma globulin. There are small amounts of IgA and IgM, other immunoglobulins in the plasma, and there are also other plasma proteins in small amounts. For those of you who like to play Trivial Pursuit, 1 gram of gamma globulin contains about 4 times 10 to the 18th molecules of antibody. What does that mean? That means that there is a lot of specific antibodies to a broad range of pathogens, both bacterial and viral, in the gamma globulin. And as you can see from the slide, this turns out to be about 10 to the 7th power. And that's what helps protect patients with antibody immune deficiencies from getting infections with certain bacteria and certain viral pathogens. The immunoglobulin or gamma globulin also contains either sugars or amino acids as stabilizers, and this differs for each product. And the slide does note what some of these sugars and amino acids are in some of the various products, some of which you may have been on in the past or currently. And the purpose of these stabilizers is to prevent the highly purified IgG from coming together or aggregating, which can result in side effects like headaches, joint pain, back pain, low-grade fever, chills, etc. The newer products are essentially all liquid, very different than what we had available prior to the year 2000, when most of the products were powders or lyophilized, in which they had to be reconstituted. Those older lyophilized products, when given intravenously, were the ones that cause a variety of side effects, as I said before, the most common one being headaches. With the newer liquid products and the use of the certain sugars and amino acids as stabilizers to keep the serum IgG in a non-aggregated or monomeric, that's another term that we use, form, these systemic side effects are much less frequent with the administration of the immunoglobulin or gamma globulin by the intravenous route. This slide shows the FDA-approved indications for immunoglobulin. Of course, the number one approved indication is as replacement therapy in patients with primary immune deficiencies, such as those with antibody immune deficiency disorders. There are a number of other approved indications. Some of these are as adjunct therapy in certain inflammatory disorders or other disorders in which there is a risk of infection. The other FDA-approved indications are for certain autoimmune disorders, such as idiopathic thrombocytopenic purpura is a good example, and some of the autoimmune neurologic problems, which are the last two indications noted on the slide. But today we're really going to concentrate our discussion on immunoglobulin as replacement therapy for patients with primary immunodeficiency disease, or specifically patients with antibody immune deficiency disorders. I just want to say a word about viral safety. This is one of the most common questions that I receive from patients and parents of children with immune deficiency. It was actually fortuitous that the first step in the manufacturing of purified immunoglobulin was a process called cold ethanol fractionation, which actually inactivated the HIV virus. A common question I get, again, from parents and patients. Through the years, there have been a number of advances to ensure the safety of immunoglobulin with regard to the potential passive transfer of a bacteria, but particularly a virus, from the immunoglobulin preparation to a patient with immune deficiency. At the pre-production stage, as I mentioned before, normal individuals donate plasma through these plasmapheresis centers. They undergo extensive screening, both by a questionnaire as well as by a physical exam. Blood is obtained, and the serum is tested extensively for the possibility that an individual has one of the viruses of concern, such as hepatitis B virus, hepatitis C virus, and of course HIV. After that subject donates plasma, that plasma is held in a frozen state until that individual comes back for a second donation of plasmapheresis. And then that subject obviously gets tested again, and if tested negative for all these various viruses, then the first plasma donation is released for manufacture of the immunoglobulin. Now, through the steps of purification, there are a number of important steps which, if any viruses did for some reason sneak through the pre-production phase or the donor screening phase, that virus would be removed by either adding certain substances. One common one is solvent detergent. One manufacturer uses pasteurization to inactivate any potential bacteria or viruses that may have somehow gotten into the plasma. And then finally, there's another process of viral removal by a termination step that's often referred to as depth filtration, nanofiltration, and other terms are used. And that also is geared towards removing any potential contamination of the immunoglobulin. So in summary, I'd have to say that today's products is probably about as safe as you can possibly make the immunoglobulin or gamma globulin for the administration of patients with underlying immune deficiency disorders. Through the many advances that have occurred over the past 20 years in not only donor screening, but also the manufacturing or production of the immunoglobulin. Now, I wanted to mention a couple words about the intravenous route of immunoglobulin replacement therapy. One of the common symptoms patient may experience by using the intravenous route is something called wear-off, and this occurs about a week prior to the next scheduled infusion. It's a rather vague term in that it means that patients are feeling less well. They may have some fatigue. They may have some symptoms, including a cough, or maybe more of a runny nose or congestion, which are kind of, very soft, subjective signs and symptoms, but nevertheless is a fairly common occurrence, as you'll see in a minute, in the next slide, of something we call wear-off. So the present slide just shows you a diagram of what we mean by when wear-off occurs. The orange line is intravenous immunoglobulin replacement therapy. You can see about a week prior to the next scheduled infusion, when the immunoglobulin serum IgG levels are at their lowest, this is when patients may experience some of these symptoms. Now, not all patients will experience this wear-off, but in a Immune Deficiency Foundation survey performed in 2003, you can see that many patients receiving intravenous immune serum globulin did experience some degree of wear-off. Now, around this time, we were switching over from lyophilized to liquid IVIG products, so it may be that this particular signs and symptoms, which we call wear-off, is less of an issue with those individuals receiving intravenous immune serum globulin. So let me say a few words about subcutaneous immunoglobulin replacement therapy. Certainly, if patients who are on intravenous immune serum globulin and are experiencing wear-off effects, or if they're experiencing systemic symptoms, particularly headaches, and if these are severe, this is certainly one or two reasons to consider switching from IV or intravenous immune serum globulin to subcutaneous immunoglobulin. For those of you who are already on subcutaneous immunoglobulin replacement therapy, this is very familiar to you, but for those individuals who are still on intravenous immunoglobulin, I just want to explain a little bit more detail of what's entailed. The first question that comes up is, where can we infuse the immunoglobulin subcutaneously? What do I mean by subcutaneous? Subcutaneously means that it goes under the skin and the subcutaneous tissues. So we generally tell patients that if they can pinch an inch on the body, this would be a good place to place a needle for the subcutaneous infusion. Common areas are in the abdomen or on the lateral portion of the thigh. Less common regions are in the back of the arms and on the lateral parts of the buttocks, but these are used much less commonly. We generally infuse for the subcutaneous route, depending on how frequent we infuse. We may start out weekly, or we may actually go to every other week. And in fact, with the newer products, the 20% subcutaneous products, which have become available, I try to get most of my patients on a every other week infusion schedule. Infusions generally take 1 to 2 hours. It's given with the assistance of a mechanical pump. However, some patients elect to give themselves the subcutaneous immunoglobulin on a more frequent basis, much like a diabetic individual taking daily doses of insulin, using small amounts of immunoglobulin in a syringe and just pushing it in over 5 to 10 minutes. So what does this translate? This translates into a very flexible schedule for the patient. So the subcutaneous immunoglobulin may be administered weekly, and may be administered every other week, or it can be given more frequently, 3 times a week, or even in small doses every day if the patient so chooses to do that. Now I know what you're thinking. You're thinking, well, how much can we put in each site? How much volume of gamma globulin can we put in at each site? Generally, in an adult, we can put in somewhere between 25 to 30 ml, which is a tablespoon. However, again, depending on the product, some products are such that we can actually put in 1.5 tablespoons or even 2 tablespoons per site. This will vary depending on the patient and how much subcutaneous tissue is available for the infusion. So the volume and the rate of infusion is also very flexible, and it just depends on the tolerability of the patient, how much subcutaneous tissues are available. So in someone who perhaps is very lean, that individual may choose less of a volume per site, whereas someone who is not lean and perhaps a little overweight and has pretty generous subcutaneous tissue may elect to infuse a higher volume at each particular site. We individualize for each patient. That's the important bottom line. There's also another method of delivery of subcutaneous immunoglobulin, and this is called facilitated subcutaneous immunoglobulin administration. The immunoglobulin in this case, is a 10% liquid and not a 20%, but it's combined with a enzyme, hyaluronidase, which opens up the subcutaneous tissues to allow the administration of larger volumes. It enhances the dispersion and actually the absorption of the immunoglobulin administration. So in this case, we can actually give the whole monthly dose with 1 or 2 needle sticks once a month by using this facilitated subcutaneous delivery. This obviously results in a larger volume per site, anywhere between 150 mLs to 300 mLs per site, which does result in kind of a pancake swelling of the subcutaneous tissues. So again, this is a patient choice and may not be for every patient. But again, is another option for those individuals who want to use the subcutaneous route on a once-a-month schedule at 1 or 2 sites, meaning 1 or 2 needle sticks. There are some mechanics that have to be noted for optimization of the delivery of the subcutaneous immunoglobulin. One is the choice of the needle to administer the immunoglobulin into the subcutaneous tissues. Often the needle choice may be too short, which can run into issues of discomfort and local reactions at the site. So in this case, believe it or not, a longer needle is better than a shorter needle. And again, the patient can work with their physician, their clinical immunologist, and also the nursing home care company to determine what the optimal needle size should be to minimize local reactions. With regard to the pumps, which is necessary in order to, actually pump the immunoglobulin into the subcutaneous tissues, this is usually left up to the home care agency and the insurer. And for most patients, they use a mechanical pump called a Freedom 60 pump. Now, just a few words about the comparison between the intravenous route and the subcutaneous route. We've been using the intravenous immunoglobulin since 1981, so we have a long history and experience with IVIG. It is well tolerated by most patients, particularly with the newer liquid preparations that have been available since around, in general, 2000. You're able to give a whole month dose of immunoglobulin at the same time. But of course, this results in large shifts of the serum IgG and protein, which may be related to some of the adverse events, particularly the systemic adverse events that I was mentioning before, like headache, malaise, fatigue, rarely joint pain, back pain, and maybe low-grade fever, etc. It does require venous access, so you have to have a trained person to actually do a venipuncture. But home infusions are possible. There are home care companies that will send the nurse out to your home to actually administer IVIG in the home setting. So what about subcutaneous administration? Well, it's convenient, well tolerated by most patients. Be given at home. It's self-administration. You do not need venous access since you're giving it into the subcutaneous tissues. You don't get this very large bolus of protein that results in very high serum IgG levels. So therefore, the systemic adverse events or side effects that I was mentioning before, particularly headache, is a lot less frequent with subcutaneous administration. But it does require more frequent dosing. With the newer 20% products, most of my patients can be on every other week. And of course, as I mentioned before, with facilitated subcutaneous immunoglobulin replacement therapy, you can actually be on this route of replacement therapy once a month. And it does require compliance. Since there is not a nurse that goes out and administers the immunoglobulin like with IVIG, we rely on patients to stick to their schedule, whatever their schedule might be, whether it's once a week or once every other week, etc., because they self-infuse. What about the differences? Am I going to be better on sub-Q versus IV or IV versus sub-Q? And there's really no difference in the number or severity of an infection. So the efficacy is really by and large the same. On this slide, it does note under duration of infections that patients were on antibiotics less days on subcutaneous versus IV, but probably because the dose administered was higher on subcutaneous than the IV route in this particular study. So you can see that the efficacy comparison between subcutaneous and intravenous on this slide is really the same. There really is no difference with regard to protection from an infection. But as I mentioned before, with regard to systemic events or side effects, it is less with subcutaneous versus IV. And here's a couple studies shown here, one by Chappell and one by Gardoff. But all the clinical trials have emphasized this important parameter, that there's less systemic side effects with subcutaneous versus the intravenous route. The other important point that I, as a clinician, think it's important with the subcutaneous immunoglobulin replacement therapy is better quality of life. And this has been reported in a number of papers in the medical literature where there's a comparison between the intravenous or IVIG and subcutaneous immunoglobulin, that patients are just happier, more satisfied with their subcutaneous therapy than those on IVIG. Now, of course, this can vary among patients tremendously. This slide just shows, again, the difference in systemic adverse events between intramuscular gamma globulin, that's the green. The yellow is intravenous gamma globulin, IVIG, and the black, which you can hardly see in this slide, is subcutaneous immunoglobulin. This is from a study by Gardoff in the early 90s. There are some side effects from subcutaneous administration, so it's not zero. Some patients still experience headache, but it's a lot less severe and frequent than with IVIG. And there are some very minor, much less common side effects shown on this slide, such as rash and nausea. Again, much less frequent than with the intravenous route. Again, probably related to the fact, again, with the intravenous route, you're getting this large bolus of protein or highly purified IgG that I'm sure is a significant factor in some of these systemic side effects. One of the advantages of the subcutaneous immunoglobulin, as I mentioned before, with the intravenous, you get this very high bolus of serum IgG and protein levels, as shown on the right panel with IVIG. With subcutaneous, because you're giving smaller amounts more frequently, you get what we call steady state immunoglobulin or serum IgG levels. And this virtually eliminates this wear-off effect that I mentioned with intravenous immunoglobulin. In addition, given the same dose of subcutaneous immunoglobulin as what you would administer with IV, you also get actually higher serum levels of serum IgG. So this may be another important factor in the efficacy of subcutaneous immunoglobulin replacement therapy. This slide just emphasizes again the improvement of quality of life in patients before they started their replacement immunoglobulin therapy, both in children and adults. So the blue is at baseline, and then you can see that the score is up in the middle 90s after 10 months of home therapy with subcutaneous immunoglobulin. This is just one particular paper that's reported in the literature. There are many, many papers that show similar findings of improvement in quality of life with immunoglobulin replacement therapy, but in particular subcutaneous immunoglobulin therapy. So just in summary, subcutaneous, better quality of life, perhaps lower costs, especially what we call indirect costs, because patients don't have to take time off from work or school. They can schedule their subcutaneous immunoglobulin administration whenever they want, while they're watching TV or doing homework in the evening, for example. Lower systemic side effects. The trade-off, of course, is more frequent treatments. Most of my patients are on every other week subcutaneous administration. And some patients may have some local reactions at the infusion site. Commonly, these are minor. There may be some redness and obviously some swelling because you're putting volume into subcutaneous tissue. There may be some itching, but these resolve after a few days without any sequela. In fact, this slide shows that as time goes on, these infusion site reactions decrease in frequency, as you can see in this one reported study with a subcutaneous immunoglobulin preparation. So I hope I've been able to share with you the information about the actual immunoglobulin preparation, some issues around viral safety, and the improvements that have been made to immunoglobulin over the past couple of decades to make this a really safe preparation for the administration to patients with immune deficiency. I've also contrasted intravenous immunoglobulin with subcutaneous immunoglobulin. Patients have a choice, which is very nice. And it really depends on the patient's lifestyle and their tolerability to any one particular route of administration. But the bottom line is that patients have a choice, and we can tailor the patient's lifestyle and address some of the concerns and issues about the administration by using various administration modalities. And thanks for your attention.
Thank you for watching this video, and also a big thank you to CSL Behring for sponsoring this wonderful program.